All righty, good evening, good afternoon. Welcome to the MyCP webinar series. My name is Paul Gross and I will be your host. And this is where we share the work of the Cerebral Palsy Research Network with the community and give you a chance to engage with the clinicians and researchers that are putting together the work that we are doing. I'm really excited about our guest speakers this evening. We're going to be talking about wellness for adults with cerebral palsy. And we have Dr. Jim Rimmer, who is the director of the National Center on Health, Physical Activity, and Disability, joining us. He's also got a long list of other credentials that I couldn't even fit on a page. And also Dr. Mark Peterson, who's an associate professor of physical medicine at the University of Michigan. So I'm really excited to have them speak. Just to give you a quick overview of the agenda, I always start with an introduction to CPRN. So I will start with that. If you have listened to these, feel free to tune out for about 6 minutes. I am going to do it probably at East Coast pace. I'm an East Coast native, even though I live in Seattle. And then Dr. Peterson is going to talk about health and wellness at cerebral palsy. And Dr. Rimmer will then take it and talk about specifically the mentor program that's been developed. And then we'll open it up to Q&A. And I've actually asked a number of the members of the MyCP community that participated in the original pilot of this program last year to join us. So they'll be able to answer questions as well with their firsthand experience. Okay, so I want to talk a little bit about history. So the CP Research Network is a combination of two organizations, CPRN and CP Now. CPRN was born out of an NIH, or National Institutes of Health workshop that happened in late 2014. And this meeting concluded with 5 key areas that needed to be focused on. To start a national CP registry, that's a difficult thing in a country that doesn't have socialized medicine. To pursue comparative effectiveness research, so which of all the interventions are the most effective. Increase the study of adults, bring more clinician scientists into the field, and advance basic and translational science for cerebral palsy. And CP Now was founded out of the same meeting. Michelle Schusterman, who's the mom of a 14-year-old, she just turned 15 this week, 15-year-old girl with CP, started an organization, and her takeaway from that meeting was that we needed more sort of evidence-based literature to help families with the diagnosis of CP. She also was very focused on the well-being and activity programs and wanted to fund important research. So we came together in the beginning of 2021. We took our 4 website presences and combined them into one and relaunched ourselves as the Cerebral Palsy Research Network, or CP Research Network for short. Our mission combined is to optimize the lifelong health and wellness of people with cerebral palsy and their families through high quality research, education, and community programs, like the program you're going to hear about tonight. Okay, so some key milestones in this is from an education perspective. This is referring to the merged organization. We launched the CP Toolkit in 2015, and at this stage, we've had more than 4,000 people receive that toolkit. It's been translated into Spanish and Portuguese. We released a well-being guide for parents and caregivers in 2017. And then we launched MyCP, which I'll talk about in a little bit more detail, to provide personalized information. And we launched that in 2020. In terms of research, we have a registry at our core towards that first goal of that NIH meeting, which currently has more than 5,000 patients. It was launched in March of 2016. One of the first things we did was we went out and got funding from the Patient-Centered Outcomes Research Institute, and we created a patient-centered research agenda that was published in 2018 after a year of work in 2017. That's called Research CP, and that guides our work. We've had some significant public funding milestones for both the registry and for a specific genetic study that both received funding in 2019. We've launched 4 quality improvement initiatives. These are a different way to improve outcomes from core research, but they happen much more rapidly. We launched those across the network in 2020. And I actually have to update this. I realize we've had our 5th publication, more than 20 academic presentations, and we've got more than 8 manuscripts being developed currently. And then in terms of wellness, we launched a virtual wellness program in June of 2021 with Staying Driven. Talk a little bit more about that. And we partnered with the National Center on Health, Physical Activity, and Disability to pilot the mentor program and now to help sustain the mentor program. So the network is a 501c3, and what we view ourselves as a collaborative effort to organize the community to improve outcomes. And we take a very broad definition of community, all stakeholders, both clinicians that treat people with CP, researchers, but most importantly, community members and what they think is most important to improve outcomes. We have a data coordinating center, a place where the registry data, which is just a database of information about people with CP, come together at the University of Utah. And we have two registries. We have a clinical registry, which gathers data from a visit to a hospital clinic, and a community registry, which captures data about lived experience and is available through MyCP. And then we have our education and well-being programs. MyCP is a core part of this. It's a free personalized web portal that sits inside of the CP Research Network website, and it offers you an opportunity to participate. Oh, sorry, I accidentally clicked one ahead. It offers you an opportunity to participate in research from the comfort of your mobile phone by participating in surveys. We have discussions. There's a private discussion board where we have discussions with clinician researchers and members of the community about priorities and evidence base for interventions. We personalize web resources. So if you go to MyCP, you can actually go to a page and it'll tell you what based on you is most relevant for you to read on our website. And you can sign up for free at mycp.org. So just to give you an idea of what these registries have, this is one data point from these registries, and it'll show you a little bit about how they're different. So the gross motor function classification scale or system, I could have that wrong, I think it might be system, is one data point, which is about a person with CP's ability to ambulate or to have locomotion. I'm sorry, I'm checking my own English here, in a wheelchair. And you can see the distribution of, 1 through 3 is ambulatory, 4 and 5 are wheelchair users. And you can see the distribution of the more than 1,000 people that we have there. It's a pretty good mix, and a little more heavily focused on people that are GMFCS2. This is what it looks like in our clinical registry. Our clinical registry has both adults and children in it. I'd say it's about 18 to 20% of it is adults. So probably not reflective. It's not intended to be reflective of the population, but reflective of who gets treated at CPRN centers. And you can see it's a very different shaped curve of people with varying GMFCS. So that's the kind of data. That data point is very important for so many studies, and that's the kind of data that we collect. So overall, we have a set of programs. Our 4 pillars are focused on community engagement. And you see the people that gathered for Research CP in Chicago in 2017. Research and quality improvement, and that's all of our investigators when we were last together in Michigan. Our educational materials, including the booklets of MyCP, and then our health and well-being programs. So the network is spread across the United States. These pins represent sites that are collecting data in the registry if they're green, yellow if they're working on the technology end, red if they're working through some compliance like some of the agreements that we require, and blue if they've sort of raised their hand to say they want to join the registry but have not started yet. And you can find all the details of the exact locations and who's involved on our website. So we exist to accelerate research as a core part of our function, and this is just a quick glance at our research pipeline. We try to generate ideas here on the left and in a funnel and move them along, get people involved, review them, approve them, and then move them along towards funding and implementation, write about the results, publish those results, and then roll the evidence back into the practice at all of our centers. Today, we're going to be focusing on one of our 2 wellness programs. So we have the MyCP Fitness with Staying Driven, which is free to all adults and teens. You can just go to MyCP to sign up, and it offers 2 classes a week for free with adaptive fitness coach Steph the Hammer Roach. And it's been getting very good reviews from the people that have participated in that as being great for getting their heart rate up and fun to work with a group of people across the age span for cerebral palsy. And then mentor or mindfulness, exercise, nutrition to optimize resilience, which is offered by NICPAD as it's known. It's also offered by the University of Michigan, or will be offered, and other sites around the country. But what we're doing is working with NICPAD to make it offered for free through MyCP, i.e. you just have to sign up for MyCP to get access to it. And you can do that either by signing up, or if you're already a member, you just go to your profile and check the box, I want to participate in Mentor, and you'll be sent an email with all the details you need to sign up and where any sort of Q&A is and whatnot, but you're going to get lots of answers on this during this webinar. So classes kick off every month, and I think no better way to talk about the importance of wellness and fitness than to let our two guest speakers do the talking. So as I said, I've got Dr. Mark Peterson, Dr. Jim Rimmer on, and we're going to start and have Dr. Peterson talk about his work and the importance of physical activity for people with cerebral palsy, which is a very, very important fit with the Mentor program. And then Dr. Rimmer will talk about Mentor itself. So with that, I'm going to stop sharing, and I'm going to turn it over to Dr. Peterson.
Okay, thank you so much, Paul. So can I share my screen then? Is that
you should be able to share your slides just by click on the share screen at the bottom of your Zoom screen.
Yep.
Perfect.
Okay, can you hear my voice?
We can, and if you should probably go into slideshow mode, that would be best.
I think I'm there.
Yep, thank you.
All right, I'm going to minimize the picture so I can see everything here. Thank you very much for the opportunity, invitation to present tonight. It's an honor. Glad to be a part of the CPRN and greater network, and I really appreciate the opportunity to talk. Those of you who don't know me, my name is Mark Peterson. I'm on faculty at the University of Michigan, Department of Physical Medicine and Rehab. A lot of you in the audience are probably colleagues of mine. I know Dr. Hurwitz is on the line and a few other people. A lot of our work here at the University of Michigan in collaboration with Dr. Hurwitz and other colleagues here at Michigan are in the sort of the space of health outcomes among adults living with CP. Obviously, we are very interested in supporting lifelong physical activity participation for folks across the lifespan with cerebral palsy. And so that's kind of what I'm going to go through very quickly in an overview with you guys today. So originally, my original work was in muscle pathophysiology of aging. And obviously with age, we know that there is risk for frailty, physical dysfunction, mobility disability, chronic disease risk, cardiovascular mortality, and all-cause mortality, just even in the general population. So I became very interested in studying the effects of aging and CP, even in early adulthood. About 10 years ago, 12 years ago now, I have, for those of you who don't know, I have a son with cerebral palsy. And so my research interests are very personal and professional in nature. So I very clearly have interest in trying to understand the health of individuals with CP across the lifespan. So it's not just a factor of age or frailty. What happens to children, adolescents, and young adults with CP as they transition throughout adulthood? That's really what I guess the centerpiece of our work is here at U of M in my career. Currently, it should be reported that there are more adults living with CP in the United States than there are children. I bring this up because we are often faced with the notion that cerebral palsy is a pediatric disability and has nothing to do with adults. And yet we know that children with CP grow up. In fact, we have a paper that the title is Cerebral Palsy Grows Up to kind of point out that exact thing. There are extremely unique healthcare needs among adults living with cerebral palsy. Back in 2015, we published the first paper, large population registry in JAMA looking at chronic health outcomes in CP in a very large cohort of over 2,000 adults with CP, and found across organ systems there was around a 2 to 5-fold increased risk for diabetes, asthma, hypertension, heart disease, stroke, emphysema, and less surprisingly, joint pain and arthritis. Each of these were independently associated with age, obesity, degree of physical impairment, and then most importantly, physical inactivity. And so we have since studied basically every organ system in individuals with CP by doing clinical cohort studies, population registry studies, and even international work, collaborating in the UK and in Australia, and have basically shown adults living with cerebral palsy have somewhat of an increased risk for developing preventable non-communicable diseases across organ systems. While that may sound daunting, the key word preventable is the centerpiece of the talk and focus area of this session tonight. Because I do believe that as a exercise physiologist by training, exercise is in many ways a panacea for all things that plagues age-related chronic conditions. So what are the points of intervention? Again, as an exercise physiologist, I tended to be historically a maximalist, trying to get people to engage in the most activity as humanly possible. But there have been few important studies showing that sedentary behavior confers significantly greater health risk than physical inactivity. And that's not the same thing. Sedentary behavior is sitting. Physical inactivity is just the absence of regularly scheduled physical exercise. And so one of the largest studies ever published was in Australia, and just over 200,000 adults, show that time spent sitting correlated with an elevated risk of mortality for all cause and cardiovascular disease. And it seems to have been associated with mortality independent of time spent being physically active. And so if we were to think of what the first line of defense for intervening in a population, we would say, I think breaking up sedentary or reducing sedentary behavior is probably that first line. The former director of the National Institutes of Aging is kind of famous for saying, if exercise could be packaged in a pill, it would be the single most widely prescribed and beneficial medicine in the nation. Again, maybe I'm biased, but I would totally agree with Dr. Butler on that. So what are the new physical activity guidelines for Americans? And every few years, the new PAGA guidelines are published. In 2018, the latest round was published, and they expanded to include chronic conditions and folks with disabilities, which was a really important addition. And they also expanded the recommendations to discuss sedentary behavior. So essentially move more and sit less, because they compiled very, very rigorous systematic reviews showing that sedentary behavior increases the risk of all-cause mortality, cardiovascular disease mortality, cardiovascular disease, type 2 diabetes, and various cancers. And so the recommendations try to distinguish sedentary physiology versus exercise physiology into two very distinct target areas for interventions. And that's where I think we should be talking a lot in terms of the context of exercise intervention for CP. With Dr. Hurwitz and I and Dr. Olaf Verschuren in the Netherlands, we did a large study, meta-analysis, and also put together the first ever recommendations for adults with CP for exercise. We found was that with all of the published actigraphy accelerometry data, was that across, Paul mentioned the gross motor function classification system, level 1, 2, 3, 4, and 5, most highly independent, high functioning to lowest, we found was that individuals with CP across all levels had very high sedentary behaviors. And you can see this is as a percentage of 24 hours. So folks who had GMFCS level 5 had nearly 100% time spent in sedentary behavior, as compared to light physical activity and moderate vigorous physical activity. So in my mind, again, historically, sort of a maximalist trying to encourage people to engage in exercise, we need to focus on this. We need to focus on reducing sedentary behavior and moving some of this bar, all these bars down to include light physical activity. I'm convinced that that's where we're going to make the most impact on people's lives is decreasing sedentary behavior and increasing daily physical activity in that light physical activity category. Again, acknowledging that exercise is very, very important as well. But the guidelines include, I hesitate to read through all of this, but adults with chronic conditions or disability should do at least 150 minutes or just 300 minutes a week of moderate intensity, or 75 minutes, 150 minutes a week of vigorous intensity physical activity. So again, I just showed you the bar graph of physical activity taking place in adults with CP in the published literature. And I think that this recommendation does injustice to the population. I think that we're encouraging people to do far more than what's possible. And so these are the published guidelines from the American government, but I still think that we need to start focusing with fragmenting and reducing sedentary behavior first. But they do put a caveat here: when adults with chronic conditions or disabilities are not able to meet the above guidelines, they should engage in regular physical activity according to their abilities and should avoid inactivity, so avoid sedentariness. I will say that there is several NIH agenda calls for proposals to improve the guidelines for folks with disabilities for this exact reason, because this is not a good enough recommendation for the large segment of the population who have disabilities. The United States has a packaging problem. Exercise looks like a certain thing, and I have always thought that here in the US we've done a disservice to the general population, but specifically for populations who do not want to go to a general fitness center, that exercise does not have to be packaged a certain way. And so we need to get away from the old model of what exercise has been, sort of coined as and advertised as, to think more abstractly about how we can do free living exercise interventions in people's, home or community-based environments. So in summary, adults with CP are at heightened risk for non-communicable diseases due to exaggerated sedentary behavior. Clinical and public health efforts, and certainly private sectors like Cerebral Palsy Research Network, are needed to facilitate the development of preventive services, early interventions to reduce the risk of onset and progression in the aging adult CP population. I've provided some resources. I gave Paul the slides. You guys can certainly click on these at your own time and disposal. But these are fairly comprehensive recommendations for physical activity. And then lastly, I mentioned that there is a paper that we recently published called Cerebral Palsy Grows Up. It's a perspective published in Mayo Clinic Proceedings. I like to end with this because it shows the landscape of literature related to cerebral palsy in adults. So this is all papers published pertaining to adults with cerebral palsy. As of December 31st of 2021, you can see that there's a huge uptick. Nearly 75% of all published literature has taken place in the last decade. So that's promising to me. I'm really happy to see this. It certainly bodes well for the growing population of adults who are living with CP. So that's my email address. Again, thank you very much, Paul, for the opportunity to participate today. And I'm looking forward to hearing Dr. Rimmer present.
That's great. Thanks so much, Dr. Peterson. And I will make sure that your references are available on our website, on our physical activity page, and I'll give you credit for assembling those. I'm sure a number of them are there, but we'll do the work to do that. So that was great. And boy, you can pack a lot into a presentation. That was marvelous. Okay, Dr. Rimmer, are you with us? And can you take the screen?
Okay, here we go. Boy, that is a tough act to follow. That's a standard term you hear from a lot of people, but boy, Mark, you knocked it out of the park. So give me a tough job here. Thanks for that information. I learned a lot, and it's great to have a leader in the field. Both, Dr. Peterson and Dr. Hurwitz are leaders really in the understanding of the science of physical activity and exercise pertaining to people with cerebral palsy. So it's great to have these colleagues in the United States. I know there are a lot of good studies out that are published by other countries. In fact, when I started my PhD in 1979, I wanted to combine exercise and disability. And the only research I could find on people with disabilities in the area of exercise was in Sweden. And they used to do these bicycle ergometer studies with, young individuals with CP. Remember that, Mark? I mean, some of those guys, I can't even tell you the names now. It's been so long ago, but that was 1979, which was part of my dissertation. So thanks again, Paul, for giving me the opportunity to speak about a program which we created with the intention that people with disabilities will be able to, participate. So great. Let me know when you can see my screen.
We can see your slides. If you can go into slideshow mode, which you're about to do, that'd be great. And I love the new mentor logo. Okay, it's all yours.
Okay, thank you. So yeah, we just came up with this term really has a double connotation. The first connotation is we really want you to think about becoming a mentor. And so we are training health coaches, but the understanding is, we want to get a base of people who have an understanding in physical activity, exercise physiology, nutrition, et cetera, et cetera. But our hope is that we could flip this to allow you, many of you who may be interested in health and wellness to become mentors as well, because we look at this as a program that we'd like to go across the country. Now, just a footnote from, Dr. Peterson is the researcher in this co-presentation. So his work is just, jet setting. It's important, very empirical, meaning that, he studies the science of this. We're hoping that in our new partnership with him and Dr. Hurwitz, that he can also do this for Mentor. We've got a little bit of data on Mentor, but we don't have that scientific underpinning that we anticipated getting from Dr. Peterson and Dr. Hurwitz. So just wanted to let you know that Mentor is more of a program right now rather than a research project. And there's reasons for that. Very quickly, it's the way it's set up is it's an 8-week, what we call synchronous. So you do it together in groups with people using Zoom video conferencing. It's directed by a trained health coach. We have a 16-hour training program. We're going to be training one of Dr. Peterson's students in the very near future, who will go through this training, and then he'll actually develop or participate, in this online mentor program with other coaches and other participants around the country. There are 3 core wellness domains of mentor. That's what the name stands for: mindfulness, exercise, and nutrition. And I couldn't agree more with Dr. Peterson's statement that exercise is really what I usually refer to as the sine qua non, the really one of the most important, if not the most important, wellness domain that one needs to get involved in order to protect the body systems from various illnesses and diseases. So that's the way it looks. Mindfulness and nutrition is offered 1 time a week, and exercise, because of its importance, is offered twice a week. There are also 8 other wellness domains, which I'll show you in a minute. These are group-based classes. We found that social support component is very important. And we do send exercise equipment out to participants. Some of you on the Zoom today may have participated in the previous round of Mentor, but we do listen to what people are telling us, the participants. So we've got, about $140 worth of exercise equipment that goes into a Mentor bag, and we send it to the participants prior to the beginning of the program. So it's kind of a neat perk that they get to keep the equipment. A lot of it's related to handheld weights, elastic bands. We've got other types of Pilates, yoga types of apparatus that we use during the exercise program. The primary purpose is really to begin to think about, we know there's a lot more that we could be doing. Yes, exercise is extremely important, but this whole area of integrated or holistic wellness is very, very important. So we really kind of think about Mentor as touching the 3 health dimensions. Now, that being said, because we're limited in our number of hours that, we are able to work with participants over an 8-week period, we kind of are not getting at some of the key issues associated with some of the emotional or the spiritual dimension of health. And again, when I say spiritual, I'm not talking, this is all, agnostic. You could be an atheist. It's more about this whole concept, of what space are we in? How do we get here? What's this short period of time? So it really doesn't have very much to do with religion or anything like that. It's just more about grounding people in a space where, when you do get into a state of suffering, which we all do because of these mind-generated thought patterns that cause us a lot of frustration, anxiety, and depression, the spiritual part of the program is really just trying to teach participants how to use mindfulness, and some sort of spirit-based transcendence to try to help them get out of this deep hole that they might be in or they might have fallen into. So it's kind of an interesting piece, and many of the participants comment on it. It's a starter kit, so Mentor is not an end-all. It's really the beginning in working with participants, getting them to think about, this whole area of integration. And that's what the program looks like. It has an acronym, My Scorecard. So each of these dimensions of health have been proven in the literature to have substantial benefits to one's health. Every one of these, can be shown in the literature that if you participate in things like contribution to others, giving back, generosity, gratitude, that you get these enormous neuroscientific changes in the brain. People feel much, much better when they give to others. And giving doesn't have to be financial. It's really giving someone's time or making a phone call, or what we're noticing in mentors that many people, become part of a group. So when an individual is really struggling on a call, the other participants kind of join in and say, hey, we're here, we're going to support you. Don't worry about it. We'll help you get through this. So it's kind of a neat package that they get when they start to build new friendships. We did publish a study recently, which you could find through PubMed or just search online through Google, titled Retrospective Evaluation of a Pilot eHealth mHealth Telewellness Program for People with Disabilities, Mindfulness, Exercise, and Nutrition to Optimize Resilience. And basically what we found is that for individuals, there were two groups of individuals. One, these were individuals who came into the program and had a fairly good level of baseline wellness, and they made significant differences in three wellness domains. Exercise, they blew out of the waters. We had a very, very significant finding for the exercise. We had a significant finding for nutrition. They changed their nutritional knowledge and their nutritional behaviors. And interestingly enough, the third domain that changed these are people with, again, very high levels of baseline wellness. And we use an instrument called the UAB Lakeshore Wellness Assessment. But the third area that improved was contribution to others. So my early comment was there's something going on with these groups where people feel very much needed and they're giving back to other people, and having that purpose in your life, where you really see that you're able to support and assist others, really helps to improve one's overall health and well-being. Now, the other part of this that I want to make sure everybody understands is that, we don't consider mentor to be the end all. We've learned over the years that obviously, we have to reach people at a level of comfort, where they want to be able to participate, but we certainly don't feel that we want them completely to think about mentor as a home-based program and to never leave their house and never get involved in community-based wellness activities. There are a lot of programs out there that are very important to participate in. So what we've got here is, health coaches and the mentor program really put a person in the space where they're going to learn, a lot about different things related to how do I improve my overall wellness. And then once they get through that 8-week program, we were just refunded, and Paul mentioned the name, where this program is run through NCPAD. So we were just refunded for another 5 years to develop specialty programs. And what is so neat is that when you saw Dr. Peterson's slide where he talked about all these chronic diseases being higher in people, adults with cerebral palsy, that's exactly what we mean by this next stage. You complete that mentor program, and then we can roll you into one of these chronic disease prevention programs, or what we have started called the Mentor Coffee Club, which is more about just being part of a support network. So there are a couple of nice pieces that we heard from former mentor participants that they didn't want the program to end. They were very disappointed that it was only 8 weeks, and they wanted to figure out how to keep this going. So the Mentor Coffee Club is the individual can participate in that online. There are bi-weekly classes related to each of the mentor wellness domains, and that's going really, really well. We only have it at this point really in Birmingham, but we're thinking that as we grow this program across the country, and certainly with the partnership we have with CPRN and the University of Michigan, that we see this online coffee club. We actually send people coffee, by the way, and if they don't like coffee, we send them tea. But this online coffee club is really cool because people get to really interact and talk about, the different areas of their life that have some relationship to those 11 wellness domains. And then finally, after you get through that, or maybe you just go from mentor to self-management, we've got a number of resources in NCPAD that have, anything you want related to mindfulness, exercise, nutrition. We've got a ton of stuff on the website. Right now, the greatest strength of NCPAD is we've got a lot of information. The greatest weakness of NCPAD is we've got a lot of information. So we're going through a complete overhaul of the website. It's taken us about 2 years, but we anticipate that sometime between now and probably the fall of this year, we'll have a much more streamlined and customized program. So we've got lots of videos. I think we have about 800 videos on our NCPAD YouTube channel. And if an individual wants to, basically just say, I don't want the full management or the co-management, which is, related to somebody working with me, they can certainly go right to the self-management program. Everything is on the NICPAD website. You could do it on your own, and you really don't have to, you can do it any time of the day and wherever you want to do it. So with that, I just summarize by saying that what I've seen in my 41 years in research and higher education is that we're underutilizing all the dimensions of health. And so for us to think about this, right, as we go forward, there's something called precision wellness, but which I've been using, which is a kind of a spin-off of precision medicine. But the idea is that, all of these have huge impacts in terms of how one can promote their health and their overall, optimization of the activities that they're engaged in across the lifespan. So with that, I'll just stop there and say thank you for giving me the opportunity, Paul. And it's a delight to meet everyone virtually. And I hope that if you do need to reach me, Paul has all of our information. Our next mentor class starts Monday, this Monday. So it may be too late to join that class, but we're hoping to start, a new session every month beginning sometime in mid-April. Thank you, Paul.
Well, thank you. That was tremendous. So what I'd love to do now is open it up to questions, and I don't want to put anybody from the mentor program on the spot, but if in answering the question, if you feel like you've got something to add, please raise your hand and contribute, because I think it would be great for other members of the community to hear from the 9 people that participated in the pilot. So you can post a question in the chat, or if you're brave enough to turn on your camera and ask the question, or not turn on the camera and ask your question, that's up to you. But and I don't even know how to tell you how to raise a hand. I never can figure that out on Zoom. So you can try that too if you want. But does anybody have a question? Let me see. That's what I'm hearing. There is a question. So there's a question. I'll take this first one. I'm also being asked to start using a cane or a walker, and I'm having trouble integrating that into my pedestrian lifestyle in New York. Is Mentor meant for me who is in a state of health transition?
Yes, good question. And thank you for that question. It originally, when we started Mentor a couple of years ago, we really thought about it as being this transition from rehabilitation to wellness. We actually call it the R2W program, because there's really no opportunity when people leave the hospital or the clinic to continue to recover. Once insurance ends or rehabilitation ends, there's not much out there. And of course, we know that, if you look at a coin, the opposite side of the coin, right? You've got health on one side and illness on the other. When you're ill, you're kind of in the healthcare system. But what we'd like to see, in this person who put this note up, is that we flip it, right? And we can work with you, right, through the mentor program. Now, we can't give you one-on-one at this point, it'll be more group-based, but everything is adapted in the exercise area to help you sort of recover. And the other part of this is you also have this group-based class, health coaching class, where you could ask questions and we could help you with that. And by the way, you're not the only one I've heard that from. Gaining 30 pounds is rather common now. We're hearing a lot, and I'm sure there's research in the literature, right, Dr. Peterson, where people have gained huge amounts of weight, and the health practices have been, the health habits have been sort of not as proactive. Do you have any data on that, Dr. Peterson? Not for CP in general, but just the general population during COVID.
During COVID, yeah, no, I mean, the rates of participation have gone dramatically down just across populations. And obviously that comes with weight gain, poor health outcomes, and I will say, unfortunately, poor mental health outcomes as well. So that goes for virtually every segment of the population. So certainly for folks with barriers, that could potentially be worse.
Yeah, and I'll just make, thank you for that. I'll make one comment to this person. Please stay in touch with Paul, because we are adapting a program called Status Slim, which is this evidence-based program that has been proven with mindfulness and proper eating habits, etc., to really be quite significant in terms of the amount of weight loss. So we have that program here at UAB with Dr. Jim Hill, who joined us 3 years ago, and Holly Peterson, who's an endocrinologist. And we have a PhD student who is adapting that Status Slim program. So that weight loss program would be perfect for that individual who put that comment in the box. We probably won't start it for, probably 8 or 9 months, but in the interim, please join Mentor and stay in touch with Paul. Let me know who you are. He has my email address. I'd love to talk with you offline.
Great. Thanks for that answer, Jim. Okay, I know Amber was, I see your hand up, Poonam, but I know Amber was unmuting to ask a question, so.
I'm sorry, I must have put it up by accident. I don't have my question yet.
That's totally fine. Poonam, you're up.
Hi, so thank you for the presentation. I had a question for Dr. Peterson. I know you mentioned that the recommendation is, like light physical activity. So for a person who uses a wheelchair for most of the ambulation and getting around, what would that look like? So if they had to go out for a walk, how would that look like for a person?
I mean, that's the question. That's the best question that we always get. And what that means basically, if your recommendation is to go out and get a walk, which is again what the physical activity guidelines recommends, using a wheelchair as a device in and of itself is to me is a very good strategy. The person who had the question earlier said swimming. Obviously, there's restrictions around swimming, but aquatic-based exercise is a tremendous stimulus to the cardiovascular system and muscular system. I personally am very biased, and I'll just point that out, that I think resistance exercise is critical to maintain health and function for folks with CP, simply because it has a direct stimulus to the muscle, not just function, but also the metabolic health of the muscle. And so while it is important to engage in aerobic-based physical activity, I'm really trying to advocate for even home-based resistive exercises. And so, some of the stuff Dr. Rimmer mentioned with the home-based types of interventions are very much based on the notion of overloading the musculoskeletal system and not just thinking of exercise as packaged as an aerobic-based physical activity or repetitive physical activity intervention. While that is very, very important for cardiorespiratory health, a lot can be done with even basic resistive exercises, seated basic resistive exercises. And again, if you want to go to maybe the best place on the planet for information, NICPAD has hundreds of videos, hundreds of tools, exercise intervention ideas. So that is a great place to go for options for types of exercises that can be done. But I can't stress enough that while physical activity, aerobic-based physical activity is really important, resistive exercise, strengthening exercise is, again, in my mind, just as, if not, I dare say, more important than trying to engage in aerobic exercise. So take that to heart, and that's, again, my biased thought, but I really think because of what we're seeing with early onset frailty, resistance training is critical.
Thanks. Thanks, Dr. Pearson. Before I go to Amber and June, or June and then Amber, I just want to ask if any of the participants from the last one want to comment on the resistance as an exercise and like just experientially what they thought of that aspect. No pressure if you don't want to comment. Go ahead, Nicole.
Yeah, I found the resistance exercises very helpful for improving my arm strength. Particularly, I have very weak wrists that are prone to carpal tunnel. So the exercises that I think it was Catherine, the exercise instructor, she gave exercises that adapted to my wrists that I could use to help strengthen my arms. And I've actually had a much less wrist pain since doing the mentor program and keeping up with those exercises.
Great aspect. Anybody else want to follow on to that? Okay. June, your hand was up.
Yeah, thanks, Paul. I'll turn the video. Hey, Jim and Mark, you mentioned that the deep holes, regarding those deep holes, and I've been hearing a lot of anecdotal reports from peers concerning, loss of more functioning during this kind of lockdown, COVID, stay-at-home 2-year period. And I'm wondering, are any of you mentioned, you alluded to weight gain and that kind of thing, but is anyone really looking at this in a focused way? And to your points, Jim, is this environment helping you to recruit more people, generate more people? And is there a telehealth component in terms of maybe working remotely with trainers? Some people might not want to go through a 6-week, 8-week program, but it's offering those other kind of solutions.
Wow, thank you, June. June's a good friend of mine, by the way, so I sent her the question in advance.
I will.
June, I go way back. Yeah, that is a great idea. I didn't even think of that, June, that we just hired a full-time personal trainer, who's going to be part of Mentor. He's got a lot of time now, so maybe this is the time. Yeah, would you like to be a case study or something? We
Yes.
can figure this out. The other thing is, as Mark knows, we got access to exercise physiology students. I don't know about you, Mark, but we got hundreds of students that kind of sit around and try to figure out, how to get internships and help people and facilitate. So that is I'm going to write that down as soon as I finish speaking. That's a great idea. And I'd love to have you be the first one, kind of go through this. We could do the assessment online, which we do, and kind of get some recommendations. The second part of it is, are people reaching out to us? And the answer, and sadly, is we're not getting a lot of, people. I don't know if it's because we're not reaching them. In fact, I know Nicole is part of our program now. You might want to say something, Paul and Nicole, about that. But, we've got a small, subcontract to CPRN to help us to try to find people. Yeah.
Okay, sign me up, Jim. I'm here for you.
Yeah, and as Jim has emphasized, don't hesitate to reach out to me if you feel like you need something tailored. And before I go on to you, Amber, I want to ask Jim to address a request that I think we got during our course, and see if there's any new thinking in that Andrew placed, which is, he says he goes to college 1 day a week. Can one do the course if they have to miss 1 day regularly? And B, is there a plan to make the course available outside of business day hours at any point?
Yeah, that's a tough one, and thank you for that question. We thought about this because of our bandwidth, right? We're in the central time, and we've got to address issues with East Coast, West Coast. We're kind of limited in that capacity because most of our staff can't leave them. They can't really stay here on campus till 5:30, 6 o'clock. So we're trying to do as much as we can. But that being said, we are taping all of the classes. So you would have access. If you could only do the exercise 1 day a week or just the nutrition, that's okay. Because again, this is not a research study. This is a program that's publicly available. And certainly there are no requirements associated with it. So yes, you can do that. Just let your coach know when you sign up. And, that'd be a great, at least you get part of it, and then you could listen to the videos for some of the classes you missed.
Okay, thank you for that. This is Andrew. I also do attend the gym twice a week, so I do that for exercise.
Okay,
So
yeah, good.
Thank you for that answer.
Yeah, are you back?
Go ahead.
Are you back on the exercise circuit? I know we just kind of reopened. So are you open now?
Yeah, I'm back at the gym twice a week. So
Okay, super.
And
thank you.
Jim, I don't know if you heard us mention, we run a 2 day a week. We partnered with Steph Roach, and we run a 2 day a week virtual fitness, which is great for people with CP. Although, as somebody mentioned, that it didn't work for her given her physical situation. Amber, I'm going to turn it over to you.
Yeah, I was wondering, muscle atrophy is common with everybody as we age, but I know that people with CP don't have normal muscle fibers. There's more C fibers than there are of the other fibers. So how, are you looking at what the best way to exercise is to increase those muscle fibers that need to be increased, and how to prevent muscle atrophy? Because it seems to be greater in the CP population compared to the non-CP population. And so I'm just interested in that, if that makes sense. I'm not sure if my question did.
So I don't know if Jim minds, but I'll take that question. Again, yeah, there is a greater risk for sarcopenia or muscle atrophy with aging and CP, but unfortunately it starts from early onset. It's not that it's not just atrophy. It's a lack of overall development in general, even from childhood. So in my mind, that probably the most important component of physical activity is resistance exercise, and that is sort of agnostic to the type of fiber that muscle is. It's really important across all fibers. So resistance exercise can be tailored from low intensity all the way up to extremely high intensity, depending on a person's goals. Before getting into research, I was a strength and conditioning coach. So, designing exercise interventions is really interesting to me. And for folks with living with CP, doing resistance exercise is again, not just about function and muscle growth and muscle, size, but it's also the actual metabolic health of muscle. The number one fuel source is glucose in a muscle. And if you stimulate a muscle right, then that can actually improve the metabolic makeup of the muscle and utilize glucose at a very high level. So I'm again, very, very, very important to incorporate strength training into a program. Ideally full body strengthening that includes lower extremity strength, even in folks who are non-ambulatory, because there's a lot of muscle in the lower extremities. But core strengthening and upper body strengthening is critical to not just muscle preservation, but bone as well. Muscles attached to bone, and so if we can stimulate bone, that can help to reduce risk of osteoporosis, for example.
Great.
And do you?
Oh, I'm sorry.
Do you see, is it harder to, I guess the other part of my question is, I know there's a lot, because there's a lot of muscles that co-contract. So how do you isolate the muscle? Because it's harder to get isolation is what
Sure.
I've noticed, because you'll use any muscle that you have available with CP, where when you don't have CP, you can isolate muscle groups
Easier.
better. So how?
Yeah, I would love to have that conversation over the course of like an hour with you, Amber. Because of the neurologic component of CP, there are restrictions. Obviously, there's net contraction of the agonist and antagonist muscle. There's also spasticity of the agonist muscle that is an issue as well. There's a really good body of literature now showing that strength training can help to reduce spasticity acutely and over the long term, as well as to improve that agonist-antagonist sort of reduction or inhibition of activation. So while it seems that it's hard at first, and there's certainly pain associated with resistance training and spastic muscle, it has a huge effect on actually improving functional capacity and sort of the recognition of the nervous system that agonist has to happen while agonist kind of is inhibited across a range of motion. So there's benefits to doing it that are far beyond just the muscle itself. The nervous system adapts as well.
Thank you.
So I have to run at 3 o'clock. So there's time for a few more questions. And I don't expect that our presenters have much more time, but there was just a question about whether or not, I don't want us to answer right now a question about specific exercises to do for pain. But there was a question about prerequisites to participate in mentor in terms of cognitive or physical ability. Dr. Rimmer?
Yeah, that's okay. We'll adapt the program. If someone has, needs support cognitively to help them, a caregiver can join as well. We've had a few occasions with participants who need a little bit more help during the exercise classes. The nutrition classes are all pretty sedentary. You sit there. Sometimes you could cook with the instructor. Some people actually go into the kitchen during the classes and they actually cook along with the registered dietitian. These are very basic menus. And then with the mindfulness, there's a lot of that is just really working on breath meditation and, some of these other areas of consciousness. So yeah, the answer is, if they have an issue, that's no problem. We can certainly adapt it, and they could also help us adapt it, if somebody's there with them.
Okay, and Leon, I think the answer is no. Being a vegetarian is not a problem. But Dana, yours is the last question, and then we're going to wrap up. You're on mute. You're still on mute. There you go. There you go.
All right, my question's pretty simple. How do we sign up for Mentor? How do we even
great.
sign up?
Boy, that's the great softball. So what I'd like you to do is if you just go to MyCP and sign up for MyCP, there is a field in the sign up that says, I want to participate in Mentor. And we send you an email with a link and all the FAQs, and it'll be updated to have a link to this presentation. So it'll send you all the information. And when you sign up, please let them know you signed up and you learned about it from the Cerebral Palsy Research Network.
Okay, well,
Okay.
I clicked that box, I got the email, but there's a sign up portion?
Yeah, so it should have a link to mentor.nicpad.org, and that is the actual sign up for Mentor. But this allows us, given all the CP specific stuff, this allows us to have ongoing communication with you about the topic. Great question. Thank you for that. Let me thank Drs. Peterson and Rimmer so much. This has been super valuable. I'm going to post this. I may divide it into sections because it's just got so much richness. I really appreciate your time and also all of your individual work on these things for the cerebral palsy community. So thank you very much.
Thank you, guys.
Thank you.
Appreciate it, Paul.
Yeah, my pleasure. Bye all.
Bye-bye.